All right, we're good.
Give a few more minutes. People are still joining.
All right, looking good.
All right, Gil, you can start if you'd like.
Okay, great, thank you. Oh, hey, hello everyone. Thank you for joining us. This is our very first virtual conference, so we're excited about that. We're especially excited that you're here, and we appreciate your attendance very, very much. I just wanted to highlight a couple of housekeeping points right quick. One, your audio and video are muted. There will be 3 presentations with a Q&A following each one of them. Feel free to post any comments or questions you have in the chat room at any time. There's no limit on that one. And the conference is being recorded, and so it'll be made available to all of you in a short order. The last thing I just wanted to remind everybody, we will be having an evaluation afterwards. So we'll be giving you a link so you can give us some feedback, which is really important because this is our first virtual conference. So we really would appreciate your 2 cents in that. Let me do a little introduction, self-introduction. My name is Gil Feliciano. I'm the coordinator, the Drug-Free Communities Coordinator for the Coalition for Safe and Healthy Elgin. And we call it CSHE around here. And CSHE exists to promote a safe and healthy community for our youth, free of substance use through education, prevention, and action. Now there's hundreds of these coalitions across the nation. We're the only federally funded one in Elgin. We're made up of community volunteers from 12 sectors using an evidence-based model of prevention involving the entire community. Now, data across the nation does show that these coalitions work in the cities they're in. They reduce use because basically they're based on local data and they're led by local volunteers. Our 2 major drugs of focus for Elgin are alcohol and marijuana because they're the top 2 substances used by minors in our community. Now, none of this is possible without the help and support of our fiscal agent, which is the Ecker Center for Behavioral Health, so we want to give them a thanks for that. Now, there are 4 objectives for today's conference. 1, we want to equip you to disseminate information to your clients in the areas of opioids, alcohol, and marijuana prevention and addiction. Number 2, we want to identify the impact of COVID-19 on addiction, treatment, and prevention efforts throughout our communities. Number 3, we want to educate the community on current trends of prevention and addiction, especially within youth. And lastly, we want to identify and share additional resources. Now, without further ado, I'd like to introduce our first presenter, Ms. Jessica Reed, who will be presenting on substance misuse prevention, highlighting changes during the COVID-19. Now, Jessica Reed is an alcohol, tobacco, and other drug prevention specialist at Ecker for Behavioral Health, formerly known as Ren's Addiction Counseling Center. She earned her Bachelor of Arts degree from Hope College and began her journey in substance misuse prevention with her undergraduate internship in Holland, Michigan. Prior to working at Ecker Center, she was a prevention and education advocate for a domestic violence agency. She is a certified domestic violence professional in Illinois and is currently pursuing her master's in public health from Northern Illinois University. Jessica?
Thank you. So like Gil said, my name is Jessica Reed. I'm one of the prevention specialists at Ecker Center. And so I'm going to talk a little bit about the prevention, and then we'll go into some statistics, and then I will pass it along to people, our other 2 presenters. So I'm going to go through this. Gil mentioned our objectives, so I'm not going to read them all again to you. But I wanted to start with definition of what prevention is, because a lot of people have a lot of different ideas of what makes up prevention, and it doesn't always flow. There's 3 types of prevention. The first is primary prevention, and then we'll talk about the other 2 in a minute. But primary prevention is taking action before it's a problem so we can hopefully avoid it in the future. So I'm going to tell you guys a quick story to start with about prevention. So a man was fishing in the river when he noticed someone was drowning. He pulled them out and attempted to save them. Shortly afterwards, he noticed another person in the river and saved them too. And then he noticed another and another and another. And soon he was exhausted and realized he would not be able to save all of the drowning people. So he went further upstream to find out why all these people were falling into the river. And upon arriving upstream, he figured out that there was a broken bridge that was causing people to fall into the river and end up drowning where he had been fishing. So he decided to fix the bridge to stop them from falling in instead of fishing them out from when they were already drowning. Now he knew this wasn't going to stop everybody from falling into the river, but it would prevent a lot of people from falling in. So that's the aim of prevention, is to simply work upstream, to fix the bridge, stop people from drowning in the first place. It's important to have treatment and medical care for those who still fall in, but ideally prevention teaches adolescents and communities effective coping mechanisms, social emotional skills like decision-making and peer refusal skills, and creates a positive environment to grow up in. So that's primary prevention. That's what my focus is as a prevention specialist, is going universally to get all of the kids in the school, all of the kids in the community. Obviously, we know the communities are large, and it's not always possible to get into the whole community, but the more people that we affect, the more parents, the more students, the more community members that we affect, the better we are. The second one is, or the second and third levels of prevention are secondary and tertiary. So secondary prevention comes in when you have a group of identified students, maybe like at-risk students at school, or maybe people in the public health world that are pre-diabetic, and it's working with them to control the effects of the problem. So giving them extra support if they're at school and identified as high risk for substance misuse disorder, there's working to give them the additional support that they need. Tertiary prevention is once people have been, so for instance with diabetes, they've been diagnosed with it, and it's to help with the treatment and rehabilitation to prevent future problems because of the disease. So we don't focus on that as much in the community because that's very specified and a very small, you can see it's about 5% of the population. But the secondary, we do some of that as well. Now, prevention isn't a cure. It isn't a treatment. It isn't necessarily just counseling to make things better. It isn't, you know, people say, oh, you're going to like fix everything, all these problems. Well, no, it's not going to make it go away, but hopefully it prevents and delays use. Hopefully it prevents minors from using at a younger age, which I'll talk about in a minute. So one of the questions I get asked a lot is, does prevention work? And one example of this that I like to use is with tobacco use and smoking rates. As you can see here, this little timeline, 1965, about 42% of adults smoke. By the 1997, it was down to 25%, and now 2010, which is the most recent that I had, was 19%, and it's continued to decrease. We have figured out that smoking causes lung cancer and smoking causes all these different things. And so the prevention efforts for tobacco use have been huge. And so prevention is working. Another example that we use with public health too, seatbelt use. So seatbelt use wasn't very popular. We started doing the click it or ticket campaigns. We started, talking about how it could save lives, and seatbelts have decreased the deaths and serious injuries from car crashes by 50%. Now, everyone's like, oh, well, what does this cost? Actually, if nationwide school-based, evidence-based prevention programs were implemented across the US, it would save an estimated $33.5 billion. That's kind of the mid-range of the estimate. Some are lower, some are higher. But it would delay substance use initiation by 2 years, and fewer youth would not have used marijuana, cocaine, or would have engaged in binge drinking. You can see the statistics on the slide there. There's some estimates that for every $1 spent on evidence-based prevention, up to $10 in treatment costs are saved. The graphic on the right side of the slide it's from the American Public Health Association. For every $1 in prevention saves $5.60 in health spending. So prevention across the field works. Now there's a bunch of different theories. There's a bunch of different behind the scenes things of prevention. This is the prevention framework that we use as part of the coalition, and pretty heavily in the substance misuse prevention field. There's 7 strategies for the effective community change. 3 of them are individual levels and 4 of them are environmental levels. So I'm going to go through each one individually, but individuals focus more on one person or one smaller group of people. Research has indicated that environmental level strategies have greater impact on community change. And so we try and focus our attention on those, but those obviously are a little bit more in depth, a little bit harder. So the first one in the individual level is providing information. So this is providing educational presentations. This is providing information at tables, brochures, flyers, websites, all kinds of different information. This, again, isn't the most effective strategy, but you need to have this information out there in the community because it is important that everyone has a baseline knowledge. If people don't know that it's a problem, they're not going to be able to solve it. So that's the first one, is providing information. The second is enhancing skills. So again, similar to providing information, you want to make sure that people have a baseline of information. So this could be workshops, this could be webinars, but to increase skills, teach people about what's going on in the community, and hopefully equip them to make positive change in their community. The third and last individual strategy is the providing support for prevention activities. So this would be reducing risk or expanding protection. These pictures are all actually from different coalition events that CSHE has put on. This one specifically is an alternative night out for middle school youth, where we provide information, we provide a safe and healthy place for them that they're chaperoned. They have a great time and they kind of learn that they can have fun without having any substances in their system. So providing that support, providing information, and recruiting them for other programs in the community then too. Then the environmental strategy is enhancing access and reducing barriers. So improving systems to increase ability, ease, and opportunity. This could look differently in different communities. It could be to make sure that opportunities are available in different languages. It could be that this picture is from one of our take-back days, which with the DEA, usually they do 2 take-back days, drug take-back days a year, but they usually focus just on the pills. We've been able to work with our community to make sure that we can take back liquids. We had people come in with fentanyl patches, which usually they wouldn't be able to take back, but because we partnered with our different communities and partnered with our hospital, we were able to take those back to increase access and get those out of people's houses. The next environmental strategy is changing consequences, incentives, or disincentives. One example of this is when the police do alcohol compliance checks and people pass, sending a certificate and saying, hey, great job, thanks for supporting keeping our community safe. Let's keep it going. Another one could be with the disincentives, so social host laws. I know we in Elgin have a social host law. A lot of other areas have social host laws as well, but they all vary in their structure. So you can look into that, but the social host laws are, so if the police break up a party that there's underage drinking at, the parents are held responsible and are usually fined. I think ours is like they're fined $500 per time. Other ones are vary depending on what is going on. Another environmental strategy is changing the physical design or making environmental changes. So this could be if there are a bunch of students that hang out at a dark corner or a park. working with the city to put lights in to make it a safer place for the community. This gentleman in the picture, he's putting on bottleneck taggers, which are little tags that go on the bottles of alcohol that just say, hey, adults, this is for 21 and older. It's not for minors, and there are consequences. Like I said, we have the social host loss. So we put that on there as well. It could be going into stores and changing how, so when you walk in, sometimes you like see the alcohol right away. Going into the stores, doing environmental scans and saying, hey, maybe don't put this right by the door, maybe put this somewhere a little bit separate. So those are some of the strategies. And then the last environmental one, which is usually the most effective, is modifying, changing, or developing policies. This is also the hardest one to get into sometimes, especially as community members, but it is possible. So one example of this would be a year ago when everyone was talking about marijuana legalization and cities were deciding whether they should opt in or opt out, working with policymakers to decide what's the best for the community. Another one would be, like I said, the social host laws, maybe mandatory participation in the Illinois Youth Survey for the school districts, so that way we can gather a lot of data, that kind of thing. So as you can see from all the pictures, these clearly were all from pre-COVID times because there's no social distancing, there's no mask, there's no nothing. So what happened? We didn't just stop when COVID happened. We started working on ways to still reach the community, but in different ways. So one of those would be by having virtual events or meetings. We changed this, instead of having this in person, we made it a virtual thing so you can come from your house. The grant that I'm covered under for my job, we do curriculum in the schools. We do a curriculum called Too Good for Drugs. And they've made a lot of adaptations for social distancing, and we've made adaptations from those adaptations to make it so that we can still serve our students. Some schools are open to having people come in, some people aren't, or some schools aren't and still are all virtual. So it's just figuring out that. Also having social distancing events, like Drug Take Back Day. We're planning one for October, so we will provide information with that as well at the end or in our follow-up. But it's going to be like a drive-by thing, so you don't have to get out and touch people and see people. You can just drop it off. Having trainings, community conversations still. Social media is a big way to reach youth. Most of them are on TikTok, Snapchat, or Instagram. They're not so much on Facebook anymore. That's where parents usually are. Even Instagram is iffy with them sometimes from what I've heard. But TikTok and Snapchat, just providing prevention messaging, providing information, that kind of thing. At the very beginning of COVID, when we were all completely locked down, it was suddenly we had a lot more time to spend with our families. While that's good for some people, not so good for others, one of the positive things that we heard come out of this time is there's been more family conversations. There's been more family dinners where people aren't running off to sports and to extracurriculars and here and there and working late and everything. They were working from home. So that was the perfect time to help emphasize the point of having 61-minute conversations with your kids, not just one 60-minute conversation. So talking about expectations, talking about what do you think about prevention and the data that you research and the things that you hear. Having those small, minor conversations is helpful. And then prevention also focuses heavily on the social emotional learning skills. The curriculum I mentioned, Too Good for Drugs, it has 4 lessons on different substances, but it starts with lessons on decision-making, goal setting, communication, relationships, and emotions. So it focuses on those social emotional skills, which are clearly very important in today's society of trying to cope with all of the different changes and the worries and the anxieties. So having that emphasis has been important We knew it beforehand, and we know it now is especially important to have. And looking over data. So I'm going to show, before I'm done, I'm going to show you guys a few things from our specific county. It's from the Illinois Youth Survey, which is a survey done every 2 years in Illinois on even years. Unfortunately, COVID impacted that as well, so we don't have any current data from King County for 2020 because they can take it anywhere from January to May. And I think 2 schools in the county were able to complete it before COVID shut everything down. Unfortunately, we don't have any data, but there is some data coming out for the whole state of Illinois, so we'll hopefully be able to use that. But just to kind of lay the groundwork for our future speakers, in King County specifically, 70% of 8th grade students, 60% of 10th grade students, and 39% of 12th grade students report not using alcohol in the past year. So looking at them, they look pretty good, except for the 12th graders, which is a little low. But this is kind of a natural progression that we see year after year, because by the time students are in 12th grade, they have a car, they have more freedom, parents are a little bit more free with their, they're saying, oh, you're close enough, oh, you know, it's a celebration, it's fine. So that kind of is a natural thing. In regards to marijuana use, 91% of 8th grade students, 80% of 10th grade students, and 65% of 12th grade students report not using marijuana in the past year. I was really hoping to get the 2020 data to see how legalization has impacted this, because I've heard from students in the schools that when we would ask them like, oh, what do you, one word to describe marijuana, the first one, and if it's dangerous or not dangerous. And they would say, oh, it's not dangerous because it's a plant. When I did this with the kids in January or February-ish, they were saying, oh, it's not dangerous because it's legalized. So that changed within a couple months. So it'd be interesting to see the data that comes out after this. And I threw this one in there because it's opioids, prescription drugs. Most kids aren't using prescription drugs to get high in the past year. We find that it's more of the like college age, the early 20s is usually when it kind of is reported higher numbers, but it does sometimes start in high school. So it is something that we need to address. And then the last slide of data I have is the percent of students who think their parents would think it is wrong or very wrong to either drink or smoke marijuana. And you can see the trends, again, like I described, they go down as the kids get older, of who they think, how many think it would be wrong, but it's still relatively high. So we'll see again what happens with the current data that comes up. And so just before I pass it over, I have some resources on here that have information about prevention, about where to get information, how to talk to your kids. The image on the right is from the Talk They Hear You campaign that talks about parents, or how parents can talk to their kids and the importance of it. Prevention First is a local, or it's an Illinois prevention agency that we get a lot of our training from as prevention specialists. They have the Alcohol Policy Resource Center, and they also have specific resources available for COVID-19. They have it for prevention specialists, they have it for parents and community members. So if you go to their website and search for that, it will kind of give ideas, because obviously this is all new for everyone, and we're trying to figure out how we can best provide prevention services to everyone. So that is the end of my spiel. I'd like to introduce our next presenter. Let me stop sharing my screen so he can share his. We have Dr. Aaron Weiner, who is a board certified psychologist and owner of Bridge Forward Group, a private practice and consulting organization. He earned his doctorate from the University of Illinois at Urbana-Champaign and completed his fellowship in addiction psychology at the VA Ann Arbor Healthcare System. Prior to forming Bridge Forward in 2020, Dr. Weiner served as the Director of Addiction Services at Linden Oaks Behavioral Health in Naperville, Illinois, and the founder and clinical director of Spectrum Health Addiction Rehabilitation Program in Grand Rapids, Michigan. He's a strong advocate for evidence-based care, and he has been an outspoken advocate for numerous forward-leaning trends, including naloxone co-prescribing in hospital settings, fentanyl test strips, responsible opioid destruction, marijuana education, person-first language for stigma reduction, and vaping awareness in youth. He has spoken nationally on the topics of opioid addiction, marijuana commercialization, and the vaping epidemic, as well as served as a context expert for both policymakers and media outlets. So without further ado, I'd like to introduce Dr. Weiner.
Thank you so much, and thanks for the opportunity to speak with everyone today. So my part in today's presentation is talking about opioids and alcohol. One topic with opioids, which is very much in the news, and we talk a lot about, and then alcohol, where not so much, even though it's arguably a much bigger problem. And so what we'll talk about today is on both of these sides, what's going on right now, as well as just some foundational information that hopefully will help you to feel empowered in having these conversations in your communities with youth or with adults. Really feel like you can wrap your arms around it and have some actionable information. So I think that the format for today is that we'll be, I'll just be going through the slides, then taking questions at the end. So we'll plan on doing that. And if that changes, someone who has the ability to speak, definitely flag me down, because I can't see anything right now other than my slides. So without further ado, let's dive in. And first, just to set the context. Right, COVID-19 absolutely threw a wrench in our ability to cope with life in our society. This is a Gallup poll looking at daily emotional experiences of adults, and the amount of people who said that they were enjoying their life is here. This green one on the top on a day in the day yesterday, and then worry and stress are these two down here, and then here's COVID hitting, and it's just so dramatic. And I think all of us can relate to this on a very individual and personal level. Another way to look at this, the Mental Health America has online screenings, and what they found was that in terms of anxiety screenings that were either moderate or severe, here were their screenings for February, March, April, May, and then total. It's just absolutely just spiked. And the same thing actually with depression, where these were positive depression screens for severe depression in terms of March, April, and then May. It's been just a tremendous burden. Where this has come from, some of the biggest factors feeding into this has been loneliness and isolation in 62% of folks. The coronavirus itself down here at 36, current events 29, and then financial problems 24. You know, there's some other ones in there that might not be as coronavirus related, but you can see that this added some weight, and this was before even the entire west coast of our country is currently gone up in flames, quite literally. So there's this tremendous amounts of stress right now, and what this has led to is people coping in less than ideal ways. So we'll come back to alcohol in the latter half of the hour for my presentation, but alcohol sales have skyrocketed. Online sales in particular are almost up 500%. And in total, depending on the data set you're looking at, it's up about 55 to 75% in sales from last year. Here in Illinois, here's some local data that was published in the Chicago Tribune, but came from IDFPR. But you can see here that marijuana sales also, here's April, May, June, July, they've been spiking as people have been stocking up. And it's also worth mentioning that here in Illinois, our transaction size in a dispensary is also about 25% higher than national average in terms of people buying marijuana. Even other things like gambling, then also porn spiked in terms in March, and it's settled now, I believe, around like 15 to 20% higher than it used to. So really, regardless of what way you're looking at this, people are trying to deal and cope with problems, and many of them are not doing it very effectively. They're engaging in behaviors and using products that can have negative downstream ramifications. And of course, opioids are no different. This is a Washington Post article that found actually not only are overdoses going up, but they were escalating. They jumped 18% in March, 29% in April, 42% in May. And in Chicago, I have another slide on that coming up, but it's just simply a lot higher. A lot of places are showing 50% increases in overdose death. So with that, I want to transition into talking about opioids, what's going on now and what we can do about it. And the very high level overview on this is that opioids have been, the overdose epidemic has been growing in scale for quite some time now. You can see here, this is taken from the New York Times. I wish they updated this with another row of 4 more years, because this is a very striking graphic to see the red spread, but you would continue to see it spread if there was another line down there. What it looks like by the numbers is that in 2019, 50,042 deaths and overdose deaths in this country due to opioids, and that's 71% of all total drug overdose deaths. It's up 4.2% from 2018. And this is data actually that was just reported very recently, maybe just like about a month ago. And part of why this is unfortunate is that despite all the attention and effort that's been put on this, we were already seeing an uptick in opioid overdose death before the pandemic. And so that's now gone on top of that. To put that in perspective, though, the total US deaths in Iraq and Afghanistan over the entirety of both wars is under 7,000 a year. And so we're losing, gosh, like 8-9 times as many people on a yearly basis in the opioid epidemic. It's the current leading cause of accidental death in this country over motor vehicle accidents. And actually in our state here in Illinois, it is twice as high as motor vehicle accidents, and also twice as high as gun homicides. Put another way, 137 Americans die every day from an opioid overdose. And when I first started presenting on this, that number actually was 92. I think back in 2016, the number was 92 Americans a day. So it's getting worse, and a lot of folks are in this pipeline towards this early death, because there's thousands of people treated in EDs daily for misuse who aren't necessarily dead from it yet, but are potentially on their way. Here's what the data looks like here in Illinois, and you can see here that it's been going up over the years. But more specifically, and we'll go into this more on a slide coming up in a second, you can see there that the prescription opioids, that blue line, has been going up steadily, and it actually came down a little bit in 2018, although the general trend line is still up. But really what spiked was heroin, and then also synthetic opioids like fentanyl. Now in Chicago, just as a reference point, and I understand that King County is of course south of Chicago. So this is not the city proper, but just to put this in perspective, what's going on, there has been a 55% increase in death compared to 2019. So you can see on the left there, this is a graph of the emergency medical responses, EMS. You can see there just so much higher all throughout. And then in terms of, there's the runs, which are up 60%. Naloxone doses administered, which are up 57%, and the deaths themselves. And just to speak to that previous slide, you'll notice here that there are over, 10 times as many EMS, or it looks like maybe 15 times as many EMS runs compared to people who actually die. And so that's, when we talk about who's at risk of this happening again, there's a lot of people where they might become part of that last number if things don't change. 80% though of overdose deaths, at least in the city of Chicago, were related to fentanyl. So it's a huge, huge problem. And it relates to the fact that we've really seen 3 different waves in opioid overdose deaths. The first was with prescription opioids, the second was with heroin, and then the third had to do with synthetic opioids. And we'll talk more about that right now. But again, just to flash back to the beginning for a second, where this started, it had a lot to do with healthcare. This is a graph between 1999 and 2010, looking at kilograms of opioids sold, deaths due to overdose, and admissions to treatment. And you can see that the slopes are pretty parallel. They really run together. And that's part of why a lot of folks consider the opioid epidemic an iatrogenic or healthcare caused illness, because the vast majority of opioids that people get started on come ultimately from a prescription pad. And they're a lot more addictive than people gave them credit for. So this was a study, maybe it's been a couple of years now actually when it came out, but it was put out by the CDC looking at the chances that someone's going to be on opioids 1 year and 3 years later when they receive their first prescription, if they were previously opioid naive, if they hadn't been taking opioids. And you can see here that actually as of even day one, 6% of people are on it a year later, when you follow back up and say, are you taking opioids right now? The number jumps to 1 in 5 if they're on it for 10 days, and 1 in 10 if they're on it for in 3 years, if they're on it for 10 days. And if we go up to 30 days, so if someone's on opioids for a month, 1 in 3 people will still be taking opioids after a year, and 1 in 5 after 3. Those are really staggeringly high numbers, and was not the general perception of the medical community for years, which is part of what got us into this mess. Additionally, even people who are using them not for medical purposes are generally speaking getting them from physicians. So you can see here, this is a graph looking at where people get their medication when they're using opioids non-medically. In this far right cluster of bars here is if they're using it non-medically 200 to 365 days out of the year. So essentially people in active addiction. And you can see here that given by a friend or relative for free, that's the gray one, bought from a friend or relative, which is the purple one. But both of those come generally from physicians. Friends and relatives usually get them from physicians. The red line, the highest one, is being prescribed directly by a physician or more than one. And even the drug dealers, which are actually only 15% of people, that's how they get them, are from drug dealers. There's research that shows that drug dealers get them from doctors too, because they pay people to go generally either to a pain clinic or to their primary care, get that prescription, and then the drug dealer buys half of that off of them and leaves them with the other half. And they just do that every month. And that's part of how they keep their stock high. So we've really had to look hard at ourselves as a medical profession. The National Safety Council, who I work with them on their Physician Speakers Bureau. They created a monument actually to the 22,000 people at the time, 2 years ago, who were dying from prescription-related opioid overdoses every year. They carved faces into laser-etched pills and put those faces all on a wall. I actually took that picture myself. It was a really affecting exhibit. You can actually find a video and more about that online if you head over to their website, Prescribed to Death. But then things changed, moving into heroin and fentanyl. So part of why this happens is that when you get addicted to opioids, you might start with pills. Many people do. But then eventually you start to develop a tolerance, and it starts to become a really expensive habit because the pills have to come from somewhere, usually from pharmacies. Heroin, however, is cheaper because it is does not have to come from physicians and pharmacies, and it is less safe. It can be, and oftentimes is, cut with things, including, and this is part of what's leading to the overdoses, fentanyl. So what you're looking at here is a photo of a lethal dose of heroin on the left, and then a lethal dose of fentanyl on the right. And you can see there that there's just like a few grains of that in there to be a lethal dose to someone who's relatively naive to it. It's literally 100 times stronger than heroin. And so what's been happening is it's very easy to ship fentanyl into the country. You can basically put it in a package being sent overseas. And it's so tiny, you can get so much fentanyl in such a small container that it's much easier to get that in. And so a lot of times what we're seeing is people mixing fentanyl in with heroin to give it a stronger punch, but then they do it wrong and they end up accidentally killing people. I mean, it's worth mentioning, drug dealers do not want to kill their customers. That doesn't serve them well in any way, shape, or form. But it's not necessarily an exact science when you're on the street. And that's part of where this trouble comes from. It's also worth mentioning that it's a moving target. So this is another drug that just came out, another synthetic opioid called ISO for short. It is basically just as strong as fentanyl, but it is synthesized differently. And part of the issue with this is that it is not, it won't be picked up necessarily on drug tests either in the same sort of way, because it's got a different chemical composition, different metabolites, things like that. So in some cases, it's not even illegal. I'm not sure if ISO falls into that category right now, but if the chemical structure of a drug is different, then the regulation has to catch back up to it so that they can schedule it and even make it illegal. But honestly, even that aside, it is not hard at all to get drugs on the dark web, if not in other places as well. That's where people order a lot of designer drugs like this from, as well as psychedelics. So let's talk a little bit about what we've tried for the opioid epidemic, what's worked. So we know that opioid relevant state policy works. So pain clinic regulations and a prescription drug monitoring program mandates. So for those of you who are not familiar, and I think now every state in the country, every time you go to a pharmacy and pick up a controlled substance, that information gets sent back to the state to a database that any physician can see when they are prescribing. And so the mandate basically says you need to check it, because if someone's been jumping around from doctor to doctor or dentist or whoever it is picking up prescriptions, that's going to show up on there because they've gone to pharmacies to pick them up. And then you, as the physician, do not add to that problem. And these have led to really profound drops in overdose death decreases in Florida from that first study, nationally from the second, from prescription overdoses. If you don't regulate pain clinics, we found that it does change prescribing behavior just doing the PDMP, but mixed results on the overdoses, perhaps again speaking to the really important part of pain clinics in terms of where these prescriptions are coming from. There have also been insurance strategies that have worked. So provider lock-ins for prescribing, saying that there's only one person, if you're in a state that's done this, only one physician who can prescribe opioids to you. And that's been found to be effective. And then also utilization review and providing feedback to physicians and other providers. So basically having people on the insurance side look and say, wow, like this person's been getting a lot of opioids, or it looks like they're on a really high dose. I'm just going to reach back out to the physician, make sure that they're on the up and up about this. That's also been found to change prescribing patterns. So there's a lot of other interventions that have been promising, but just don't have the data behind it. And so there's a lot of anecdote, maybe some preliminary data, but this, the rigor that we usually look for in data, not quite as strong. These are things like naloxone distribution. So naloxone, that's the antidote to an overdose, making sure that's in the hands of as many people as possible. Again, promising early results, but in terms of our normally what we look for data, just not there yet. Good Samaritan laws, so saying if you call emergency medical services when someone's having an overdose, then we're not going to charge you with anything. If there's paraphernalia or other drugs, you're going to be fine. We just want to save their life. Police diversion programs, where when someone can either go into a police station or call the police and say, I want help. And then the police will basically take them to treatments, destroy the drugs, not charge them. There'd be no legal issues from that. And then provider and patient education, letting people know what they need to know in order to prescribe and then use opioids safely. Clinical guidelines have also been useful in terms of changing clinician behavior. So in terms of new approaches, things to be very aware of, maybe even advocate for in your community. So fentanyl test strips are really, really useful drug tests, essentially. Basically what they are is you take anything, so this could be heroin, but it could also be cocaine, anything. You put it in some water and then you dip a test strip in, and if there's any fentanyl in there, the test strip will show positive. And what's been found is that does save lives, because again, people don't want to overdose on fentanyl. They oftentimes don't know it was there. So they'll know I should not be using this particular batch. And if they have them, they do use them. Research has found that as well. So fentanyl test strips are a really promising new angle. Opioid denaturing kits and drop boxes. So when you think back to that graph of where were people getting their opioids from, a lot of them were left over opioids from, like say, hip or knee replacement surgeries, or wisdom teeth coming out, or just something like that, where you hold on to it. So how do you dispose of opioids properly? Because you can't just throw it in the trash, and you're not supposed to flush it either. There's multiple ways to do that now, including drop boxes at a lot of police and fire stations, some pharmacies, some hospitals. You could look that up. A lot of counties have a database of where those are, or if you call your local police station, they should be able to direct you to one. But then also you can buy denaturing kits, which are these little pouches. They cost $5 or less. A lot of prevention groups actually might even give them out for free. But basically what you do is you stick the drugs in there, and it doesn't have to be opioids, but it could be anything. You put the drugs in there, you add water, you shake it up, and it turns it into this inert mush, essentially, that no longer functions as a drug anymore. So that's another way to get rid of them. So specifically speaking, what can you do? I've got some actionable ideas here that can be useful in terms of us all doing our part to push back against what's going on right now in the opioid epidemic. Because again, it was already actually still getting worse, and COVID has just absolutely blown everything up, and we're a lot worse now than honestly we were in the past. So things to keep in mind that I think can be useful: detection, education, and referral to treatment. And we're going to talk about each of these now. My understanding is that I have a bit of a varied audience today. So for the assessment part, some of this might be more applicable for some folks than others, or maybe you can adapt it to your work and your environment. But I apologize in advance if there's a couple folks where the next couple minutes might not be as applicable. But it is crucial for primary prevention to actually know if something's going on with substances. It's absolutely critical. If you don't know that someone's having a problem, you can't, or even if they're at risk, then you can't work early on them. For the most accurate assessment, you want to look for a convergence of data between a clinical interview and valid screening measures. And again, depending on your situation, that may be more or less feasible. Additionally, if you have access to a medication list, a PDMP, if you work with a physician, and drug screening, if that's appropriate, all of these things can be very useful to see if someone has a problem. So this actually might technically be more like secondary prevention, but certainly there's some in the first couple, some primary prevention opportunities as well. So when you find someone and you think they might have a problem, the main areas to assess are: one, what is the purpose behind use, opioids or otherwise? For some people, if they're taking it for pain and it's well controlled and it's not excessive, that's one thing. But things for like alcohol, which we're about to get to, marijuana, if people are using it to say cope with problems, that's a huge red flag, because we're all stressed out right now, even not in the middle of pandemics and race riots and everything else that's going on in the country right now. There's still a lot of stress. And so if you're trying to cope and this is your go-to, that's the sort of cycle that often gets to be a problem. The quantity that's used. So sometimes there are just sheer amounts where you'll hear someone say, I'm using this much of something, and that will just be concerning in and of itself. Quantity alone isn't necessarily the best indicator, but sometimes, again, if it's a notably large amount, that can be useful to know if it's a problem. The third is control. Can someone stop if they want to? People have variable abilities to do that. And when I say stop, I don't mean maybe for like a week or 2 weeks, but like if someone actually sets their mind to it and say wants to stop for a month or 2 months or indefinitely, does it work, or does it seem to kind of like just go back after a little while, and are they just like what's called white knuckling it through? So do they have control over their use? And lastly, are they having consequences? And this could be in a number of different areas. This could be health, this could be legal, this could be family, social, financial, any number of different areas. But basically the core idea here is if someone is continuing to use a substance that's causing pretty significant issues in their life, that's a big red flag that this might not just be like, say, a harmless way to relax anymore, if it ever was harmless, but it might actually be growing into something a little bit different. So specific to opioids, things that are useful to know is, are they having issues with chronic pain? behavioral health diagnoses, other substance use disorder concerns, or are they currently taking benzodiazepines like Xanax, Klonopin, Ativan, things of Valium, things of that nature. All of those are associated with having an opioid use disorder. If someone is taking opioids, how much do they ever deviate and why? That's a big issue, right? If someone's taking it, are they using more? Because you can then determine a risk of chemical dependence related to dose, because there are certain cutoff points where people are more likely to overdose. Now, something again that's just useful for anybody, regardless of your profession, is knowing how much of an opioid someone is taking. And to be honest with you, even a lot of physicians don't know, because all medications aren't all the same in terms of their strength. So I've got a link here to and I can send out these slides afterwards as well, but one opioid calculator. And so I'm just going to pop us over there for a second to look at it. Here's how this works. You go down here, and again, this is if you're working with someone and you're asking, so how much are you using? It does a conversion factor to a morphine equivalent dose, or MED for short. Now, ideally, you want someone to be under 20. And so morphine is a 1-to-1 conversion rate to hydrocodone. So a Norco or a Vicodin is 1-to-1. So if you were taking 4 5-milligram Norcos a day, that would be 20. So that's really, we want people under that if they can. Now, where things start to get dicey, and this particularly happens if someone has chronic pain, is they might be on a lot of different things. So oxycodone, for example, or Oxycontin is 1.5 times as strong. So if they are, say, on 40 milligrams of that, that actually turns out to be 60. And then sometimes they're on like a fentanyl patch throughout the day. And then they also have, like they say they've got, this here is Dilaudid, which is a 4-to-1 ratio. So if you put 20 on there, it goes up to 144. And things start to look very different, right? This no longer is a 1-to-1. Now, part of why this is important is that people have a 2 times as much of a risk of overdosing if they're on 50 or more morphine equivalent doses per day, and 8 times as likely to overdose if they are on 100 or more per day. The average amount of morphine equivalents in someone's blood if they die of an overdose and are in the morgue is 98. So that can be a really useful benchmark in terms of helping people understand how much they're actually on, because sometimes folks, if they're taking it for chronic pain, don't realize, wow, I'm actually taking a very considerable amount. And to be perfectly honest with you, it is not uncommon to see people on hundreds of morphine equivalent doses a day, even at young ages, even not right after surgery. I was doing a lot of this work as part of Edward Elmhurst Health with the medical staff there, and 300, 400, 500 even sometimes. You would see when we were really crunching the data of what was going on in some primary care clinics. Really concerning stuff, but it's if you're able to talk to people about it on a very specific level, it can be helpful. So let's go back to our presentation here. Another useful resource to look at is actually the COM, the Current Opioid Misuse Measure. So actually we will go back to our web browser where I have it here. But the COM, basically, what this is, it's free to use, and it's a scale that assesses for the risk that someone is using their opioids inappropriately. And so this first page tells you how to score it. And then here are all the questions. And it's something that these folks, painedu.org, actually will license this to you for free to use in its paper form. And they ask questions like, some of them are very direct, things like, in the past 30 days, how often have you taken your medications differently than how they are prescribed? And then some of them are different, like, are you having problems, or getting more latent aspects rather, like, are you having problems thinking clearly? So just a useful tool to have in your back pocket if you have the ability or the need to pull it out. And it is really actually a very well validated measure. Now, the second thing that you can do is education, and that's the public is oftentimes unaware of options for their pain, and that actually there's very little to no empirical support for opioids in non-malignant, so non-cancer related chronic pain. It's a very high risk, low benefit treatment. And you'll develop a tolerance and a chemical dependency and maybe a psychological dependency on it as well after a while. So there's a lot of other things that can be done. And I'm not going to go through all of them now for sake of time. I should also say I appreciate everyone sticking with me as I talk quickly today. I have a tendency to cram as much as I can in and do a presentation just because I think it's all really useful information and I don't want to leave anything out for you. But I know that means I go quickly. But have effective alternatives been attempted? And so this is something where if someone's not working with a pain clinic, for example, on those alternative interventions or doing something, opioids might not be the best option there. And actually, a lot of people aren't aware they're taking an opioid. One of the findings from the National Safety Council's work on opioids was that I think the percentage was 60%. 60% of people taking opioids at the time, at least 2 years ago, weren't aware that what they were taking was an opioid. They just thought it was some sort of painkiller. So there's really a lot of opportunity here for awareness if you come in contact with someone who might have an opioid problem or be at risk. Now, the last part is about a referral to treatment. Good linkages are essential, particularly if you've got someone on your hands who has a problem. You want to make sure you get them to help. Know different levels of care and medication-assisted options in your area. So not everyone needs to go to a residential program. Sometimes just a therapist is enough. Sometimes an outpatient program like an IOP, intensive outpatient, or a PHP, partial hospitalization is enough. But know what's around, really make sure that you're well linked. And then also know who has medication-assisted options. Things like buprenorphine, methadone, naltrexone really are the gold standard in treatment right now when combined with psychosocial interventions. 90% of people who have an opioid addiction relapse in the first year if they're not using a medication. 90, tremendously high. So that's a really important aspect. And just recognize as well that peer support is not the same thing as professional treatment. They both serve important functions, but they are not the same. There's a lot of skills, psychological interventions that people are going to get in professional treatment that you're not going to get from a peer support group like Smart Recovery or AA or Narcotics Anonymous. So the last part I want to touch on before we pivot over to alcohol is this. And so I know we can't have as much actual interaction here, so I'll just talk our way through it. Just a quick note that there's some mildly disturbing content here, but you might have already seen this photo actually. It was published a couple of years ago, and it's of a pair of grandparents who are passed out in the front of their car from heroin with their grandson in the back who is extremely scared. And what I'll do is I'll ask audiences what your reaction is, and I'll hear a lot of responses about things related to feeling scared for the kid in the back, sad for him, maybe angry at the grandparents, at the adults in the front for putting their kid in this position. But what I very rarely hear are people saying that they feel any sympathy for the adults in the front, despite the fact that what you're actually looking at here is the advanced stage of a disease, of a medical problem, where clearly a system has failed them. And they would never wish this on their grandson, but here they are struggling under the weight of this disease. And this is where I think it's really important that we talk about stigma, because this is something that, in my opinion, in regards to the opioid epidemic, is literally killing people. Because a lot of times when you talk to a parent who's lost their child to an opioid overdose, they rarely say, oh yeah, I knew the extent of their drug problem. I knew that was all going on. I had a feeling this was going to happen soon. They're usually taken by surprise. They're shocked and horrified. And a big part of that is that it's kept secret. And that's part of where stigma comes from. Addiction is highly stigmatized, but there's no reason why this should be the case. My one theory I have is that people take the behavior personally. Like if someone loved me, they wouldn't do this. Sometimes maybe they had another family member who had an addiction, and so they're kind of carrying around the pain and the trauma from that, and then they're putting that on the other person. But from a factual perspective, there's no reason why it should be the case. It is literally a brain disorder and a behavioral syndrome. We have pejorative words for the population, things like addict, junkie, dirty versus clean. And we have violent terms for the act of using, like drug abuse and shoot up. I got to give props to Jessica using the word misuse. That is definitely the right term to use. And we're really trying to get that nomenclature as widely used as possible in terms of people adopting that. We arrest and sometimes incarcerate people using, basically acting out their disease. So the question becomes, do we treat it like a crime, a moral failing, a simple choice, or is this a complex medical and behavioral problem? And my assertion is that it is the latter. It matters for a number of reasons. It harms psychological well-being of users, and actually more so than for other behavioral health issues. It has impacts on our legal, medical, and legislative system. And people who have this problem struggle to advocate for themselves, in part because they're struggling with an addiction. It's difficult to do things where they advocate. It decreases the chance that someone asks for help, which is critical, in my opinion, may also increase overdose risk. And so as professionals in some way, shape, or form around substances, I think it's on us to redefine the narrative of addiction with how we intervene with our actions and with our communication. So what can you do? Each and every one of us can start to use person-first language. So if someone has an addiction, they are not an addict. Someone has an alcohol problem or struggles with alcoholism, they are not an alcoholic, because we are not defined by a disease that we have. And this is commonplace in the rest of medical and behavioral health care. We don't call people schizophrenics anymore, right? That's not respectful, because it's basically saying someone is their disease. Now, this can be a challenging shift in addiction, because there's a lot of users who do self-identify as being addicts or alcoholics, despite the fact that the associations to those words are not very positive. Like if you just quickly, and we don't have time to do this exercise, unfortunately, right now, but if you do a word association game and write the word addict up on the board, on a whiteboard, and then just see what other words come into folks' minds around that, a lot of them are oftentimes generally very negative. But if you write, say, person in recovery on the board, it feels a lot different. And there's a lot of different associations with that. But there is a tradition in the 12-step community as calling yourself an addict or an alcoholic, and seeing that actually as basically a sign of being honest with yourself. So that being said, people can do it, but it's that what we found through research is that actually for most people is not a value add to view themselves as an addict or as an alcoholic. Again, you could say that you have an addiction. Having a problem is different than being a problem. And so unless it's something that is actively helping someone, it's not something that we in treatment generally will recommend, and certainly as professionals we shouldn't be using. But certainly if someone gets benefit out of it, they're welcome to do it themselves. Now, things that we can do is eliminate the word abuse. It has actually been shown to increase stigmatizing attitudes even in clinicians. Also eliminate clean and dirty, both when you're talking to other people, clinicians, prevention folks, as well as with patients if you're in that sort of environment, because this is not medical terminology, right? There are no dirty mammograms. You would never hear a physician say that. Yet somehow we say that there are dirty drops. That's the sort of thing, or it came back dirty. You'll hear that sometimes. That is not professional nomenclature. And so we also apply that to the word clean. You will never hear me say clean screens. You'll never hear me say clean and sober, because again, that's referencing dirty. So urine drug screens are every positive and negative. People are sober, people are abstinent. When we start to talk differently, we start to think differently. And when we think differently, society can follow our lead there. So let's now pivot to alcohol and talk about what's going on with that. So this oftentimes is how alcohol is portrayed and marketed, but unfortunately right now, this is actually what it looks like. Lines and lines, people buying boxed wine and large jugs, and just really actually a mad rush on those addictive products, which is what we were talking about here, where we've seen the weekly sales growth go way up versus a year ago, particularly online. And then also that people are buying those larger items. So what we found particularly is that boxed wine is way up. We found that 1.6 1.75 liter bottles of hard liquor are also way up. 30 packs of beer are also way up, as are 24 packs. 6 packs are actually down. So there's just been this huge run as people saw this coming of just absolutely stocking up on alcohol. So, which is not a good thing. And again, for sake of time, we're not going to go through all this, but let's just shorthand it and say alcohol is really bad for you. There was recently an update to drinking guidelines where even for men actually, it basically said that any more than 1 drink per day has negative ramifications on your health. There's a great quote from a physician involved in creating these guidelines where people were saying, well, don't you think that's a little bit too stringent or not reasonable? He said, like, listen, you could say that if you want to, but bottom line is you look at the data, the moment you add on that second drink, mortality goes up in the long term. So, this is what the science says. So this is what we're going to print and what we're going to recommend. And I think that is really admirable to not necessarily bow under that pressure, but it can hit all over your body. Alcohol does. It's very bad for you, particularly actually for young people. So this is looking at the impact of adolescent alcohol consumption on, these are cognitive skills is what we're looking at here. And on the left are in human models, and on the right are in rodents. And particularly if you look down at the bottom, you can see, so this is after that consumption, that there are verbal learning deficits, visual spatial processing deficits, memory deficits, and attention deficits. And then even some additional ones there in the rodent models. Doesn't mean that they don't apply to humans, but it does mean that it hasn't been tested yet. And in terms of neural alteration, so the actual physical layout of the brain, there's a lot of impact of, again, this increased adolescent alcohol consumption, including just a lot of structural issues. So it's a very, 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 very bad idea for a young person to be using alcohol. My portion today isn't marijuana, but it also very much goes for marijuana as well. There's a lot of information on that there. But let's also just drop back again and talk about some basics, because I think that these are useful when you're having conversations with anybody, but certainly with youth. So what is a standard drink? This is something that a lot of folks get confused, that we're talking like a 12 ounces of regular beer at 5% is a standard drink, or 5 ounces of table wine, or a shot of 80 proof distilled spirit. So 1.5 fluid ounces shot. And that's, pardon me, that's important to know as well with mixed drinks, that sometimes people don't know how much is in there. Now, in terms of what's in your blood, this is something else that I think is really useful to just have bookmarked, is a BAC calculator. So how much is actually in your blood at what point in time, and when is it safe to drive? You can also print out charts like this. There's a few good ones online if you just Google it and go to an image search. But if you go to a calculator, you can actually, let me just get this to work here. You can be very specific. So say you've got like a female and she's been drinking for 3 hours, and say she's, I don't know, let's say she's like 116 pounds, and goodness, let's say she had like 2 medium glasses of wine in a night, and maybe like a mixed drink or something with a double, so her BAC there is way over the legal limit, and it would actually take her another 3 hours to get there if she just had those 2 medium glasses of wine. Then you're under, but at 0.05, but after 3 hours. But it's very important to keep an eye on how much is actually being consumed here, and then how long it will take to get back down again to help make sure that people are safe to drive. Now, what they really mean has something to do with tolerance, of course, but this is if someone's alcohol naive, the amount of impairment you can expect at different levels of BAC. So we won't go through everything here, but just to highlight a couple parts here. At 0.15, that 1 mixed drink and 2 glasses of wine in 3 hours for that female, 380 times more likely to be in a fatal crash if someone tries driving on that. And a fatally injured driver is at 0.17. By 0.25, you're really struggling, severely impaired. It's increased risk of asphyxiation from choking on vomit. And at this point, 0.3 to 0.4, you're passed out, coma is possible, all those sorts of things. To put this in perspective, by the way, when I've done quite a bit of work in emergency departments around addiction as well. And when people admit to emergency departments for alcohol who have an alcohol use disorder, it is not at all uncommon to see someone in the upper 400s and just seem to be regularly drunk, and actually seem fine at about 0.3, which would honestly like deck a lot of us. But just to really put into perspective there, when someone's really deep in the throes of this, the impact that it has on the body and on the liver, for them to have that much in them, and how close they are, honestly, potentially to their just blood becoming toxic at a high enough level. So just some FAQs, myths, and facts that might be useful, again, for adults and youth alike. Do I get more drunk on an empty stomach? The quick answer to that question is actually no. It just hits you faster. So essentially, any substance has to get into your body through absorption through a lining of some sort. And so when you have an empty stomach, the alcohol goes right onto your stomach lining and right into your blood. Whereas if it has to go through food, it's just a slower titration, essentially, of the alcohol into your bloodstream. So eventually you'll get the same amount in you. It just hits you a lot more quickly. We vomit and black out. These are actually, in part, our body's way of trying to protect us. So when we're vomiting, our body's saying, this is poison. This is really hurting me. I want to get it out. And a lot of times, people who have alcohol poisoning problems, particularly those who are not chronic drinkers, they get there because they vomit, but then keep going. They keep drinking, and blacking out is literally like your body saying, "You're done." Like we can't be doing this anymore. What can I do to sober up more quickly? The quick answer, honestly, is nothing. It's 0.015 an hour. There are things that you can do to promote other physiological changes, like if you take a cold shower, that might make you more awake, but it's not going to actually get you sober. The idea that I'll know if I'm too drunk. No, you don't. You're impaired, right? That's kind of the idea there. You're not a good judge of that. That's why blood alcohol calculators are so useful. Another one you hear sometimes is the more I drink, the better I'll feel, which is actually not true. What we find is that alcohol has something called a biphasic effect. And what that means is that although the cultural myth about alcohol is that over time, the more you drink, the better you'll feel, what's actually found is that if you keep drinking after a certain point, you actually feel a lot worse, and you end up having a dip in terms of how you feel, rather than feeling better the more you drink. And that number, by the way, that for people, of course, of legal ages to drink and have the best experience is 0.06. So if someone were to keep and maintain a 0.06 blood alcohol content, they would get as much of the positive experience of drinking as possible with as little of the negative. But if you play around with a BAC calculator, you'll see that that is not the way that most people would generally drink. So it's worth mentioning as well that alcohol's LD50 is only 4.5 times as much as the intoxication level. So what this means is, a drug's LD50 is the lethal dose for 50% of the population. And so the LD50, so alcohol's intoxication level is a 0.08 blood alcohol level. Its LD50 is 0.45. So basically, 4.5 times as much to be intoxicated will kill you. That is a very, very, very low index for that. Very, very low 50. That is called as a ratio, therapeutic index between how much it takes to feel it and how much it takes to kill yourself with it. This would be like taking 10 Advil and 50% of people dying. Like it's that intense. So it's really actually a very caustic substance. Caffeine and alcohol are a very bad combination, even though a lot of young people put them together. The reason why, there's a couple. One is that it pulls your heart in two different directions. So alcohol is what's known as a central nervous system depressant, and caffeine is a stimulant. So it pulls your heart in 2 different directions, which is not good for it. Additionally, in terms of the stimulant side, what it can do is when your body is trying to make you pass out, it keeps you awake. And so it actually makes you more likely to overdose because some of your body's defensive mechanisms can't kick in the way that they're supposed to. Another myth is that if you want to quit drinking, you have to stop entirely. A lot of people don't, to be honest with you. What I will say, however, is that the majority of people who come to treatment do because they've tried and they can't. But sometimes people have to figure that out for themselves. Regardless, if people can, then they can. It's not up to any of us to tell them what they have to do, even if the data bears out that a lot of people do have to do it that way. And lastly, medications can help. This is something that a lot of people making quit attempts don't think of reaching out to early in the process. We have 3 medications that are FDA approved. One is disulfiram, which impacts an enzyme in your stomach that makes it so that if you drink alcohol, you will vomit violently for a while. It's very unpleasant. So it basically makes it so that you have to plan your relapse ahead by a couple of days to not be vomiting all over the place. We have naltrexone, which you can either get as a pill or as a shot called Vivitrol, and that takes away cravings and also makes it so that if you do drink, you won't get as much pleasure from it. And then the last one that's FDA approved is called Camprol, which is a craving reducer. There's a couple others that are off-label that are useful, things like Topamax and gabapentin, but those first 3 are the only ones that are on-label. So just something to know if someone's trying to make an attempt. Now, in terms of its impact by the numbers, we have 88,000 alcohol-related deaths annually. And one thing that I really want to highlight here is that is more than the opioid epidemic, but nobody cares. And I want to just emphasize that one more time. That is more than the opioid epidemic. And actually, over 80,000 people have died from alcohol overdoses for a very long time, about a decade now. Nobody has cared. We take it as a matter of course. It gets no press, even though it's the 4th leading cause of preventable death and is 31% of all driving fatalities. 36 people die every day because of drunk drivers. And it's worth mentioning that this is also, just like opioids, but again, no one seems to care about this, has been going way up in recent years. This is just between 2007 and 2017, but take a look at the increase in overdose deaths across the country. A good portion of the country has seen a 40% or more increase. In some places, it's doubled in alcohol-related death. This is huge, but again, we just take it as a matter of course because it's been here. And again, I'm not gonna steal thunder from our marijuana presenter today, but that's another big issue when it comes to marijuana is that when you normalize something and it just becomes part of what you do as a society, this is what this looks like. And we could say the same thing about tobacco. This is if you don't normalizing getting intoxicated, high, drunk, whatever it is generally not a good idea for a number of different reasons. But this is just a really stark reminder to me, and this is part of why I thought it was really helpful to be talking both about opioids and alcohol in the same hour, is that they're on 2 very different paths from a policy standpoint and an alarm standpoint, even though alcohol kills more people annually and has for quite some time. So it's responsible for 40% of all violent crime, 66% of all domestic abuse cases, and 50% of all sexual assaults. And it actually cost us about $250 billion in 2010. My hunch is that number now would be higher if it got updated, but between healthcare, missed work, legal, DCFS, all of it. Tremendous cost to society for addictive drugs. And, tobacco, again, is very similar in that way. So the last thing I want to touch on briefly so that we have a little bit more time for Q&A is how can we help? So where we can really get in here is in the part of the addiction development model from NIDA that has to do with the environment. To get at the full model, though, biology and genes combined with the environment and availability and early use of the drug to interact with brain mechanisms and create addiction in youth. And so what we can affect as a community, or for some of us as parents, has a lot to do with the environment. So particularly the availability of drugs, And that's where things like tobacco 21 are great and marijuana legalization are not. And then also the community attitudes, peer influences, and parents' use and attitudes around substances and make a difference in whether or not a child develops addiction. And again, for the sake of time, I'm not going to dive into this. I'll send out the slides, but basically the general thrust of this in terms of both in the family on the top row and the outside the family on the bottom row between risk and protective factors is you want a cohesive, well-connected family where better coping mechanisms are modeled rather than not. And the same thing outside the family, where you really don't want your child in social circles and groups where drug or alcohol use is permitted or encouraged or celebrated, because that moves things in a very negative direction. Now, in terms for parents, if you're working with parents, things that I would highlight, and again, there's a few more slides that I even would have put in if we had a little bit more time to go into this a bit more, but stay connected to your child and know the signs of use. If you start to see changes in their personal appearance, their wardrobe, the amount of money they have, hopefully you're monitoring their social media, but what's going on in there. But know the signs of use and stay connected to your child. If you know what normal looks like, you'll know when that changes. Be safe to talk to, including about difficulties and failures. If you are not someone who a child trusts they can speak to without being punished or denigrated or something you're just getting mad at them, then they're not going to share it with you when it really matters. And so you've got to find a way to both be a parent, but also be someone who's safe to share with. So again, you don't build up that hiding and avoidance. Also understand why your child is using, because there's always a reason for all of our behaviors. There's a reason why we do it, even things that look like they're counterproductive. For kids, sometimes it's social because they want to be part of a group and this is what's going on. Sometimes it's coping with things like depression or trauma from abuse that they've suffered, but they're struggling with something internally. A lot of times it just has to do with school-related stress. And now, of course, COVID as well. This is something that's very concerning to students and young adults right now for a host of reasons. But at the core, again, behavior is purpose-driven, even if it doesn't seem to make sense. So understanding what's going on with your child is critical. Provide pro-social activities and peer groups for your children to identify with. So although, again, there's no silver bullet for this, and even if someone is part of a largely pro-social group, they can fall into this, associating with those folks rather than people who identify around either something as extreme as gang involvement or even something a little bit more, a little bit less extreme, like vaping, for example, which is, of course, we just had a study where 1 in 3 high schoolers is vaping right now. But as much as possible, pro-social activities and peer groups. Promote the development of healthy coping behaviors. So these are things like you wanted to do a family meditation where everyone gets together for 10 minutes and does a guided meditation, say with one of the many quality smartphone apps that are out there, talking through tough subjects together rather than avoiding them, modeling coping yourself, exercising, so when your kid looks up to you, they can see something that's healthy, and then actually engaging with a therapist. And then reward positive behavior. A lot of times parents tend to really focus on the negative, but don't celebrate and reinforce behaviors that you want your child to reproduce. This is something to reiterate a previous point, that the behaviors serve a purpose. Understand and help find a substitute and then reward it. We've found that rewarding behaviors that you want to be repeated is actually a more effective learning strategy than punishment for a number of reasons. But one of them is, by the way, if they're towards the end of high school, they're going to be out from under a parent's thumb soon anyway, and they're going to have to really rest on their own judgment. And you can't necessarily punish either the purpose out or just from a very behavioral sense, the behavior, if it's something that the kid is doing for a reason. Have access to phones and mobile devices, and consider home drug testing if you're struggling with your child. I hear this more and more from pediatricians that it's something where it can even be done proactively in some family situations where actually a friend of mine had, their family policy, he's got, I think, 5 or 6 young kids. First one just turned 13. And his policy with all of his kids, who he's got a great relationship, is just when you're a teenager, we drug test you once a month. And the reason why they do that is not because they don't trust them, but because it creates a structure for the child to work with, and knowing that they wouldn't be able to do it anyway, even if they thought about it. And then also that they can use that excuse to get out of situations where they're feeling peer pressure. Being able to say, like, my parents are crazy, they drug test me every month. That's actually a way out of a difficult social circumstance. And teaching refusal strategies is a big part of prevention, particularly with vaping. So to sum it all up, and then hopefully we can take a little bit of time. I might be a little bit over, but I'll go with the organizers' preferences on that. In summary, COVID-19 has worsened an already increasing self-medication problem in the United States. Pretty much every category you can imagine has gone up as people try to cope with this really heavy weight. Overdose rates for both opioids and alcohol are rising, and even those lesser consequences right along with it. Again, alcohol is one of those things. I don't have a good solution for how we can raise the profile about that, get the public, get lawmakers to care. But it's actually a larger problem than opioids, and has been for quite some time. Stigma keeps these problems from being treated early in their development. So really, please, if there's one thing you take away from this presentation, watch your language. Really try to hold yourself accountable, and even better, in a friendly way, the people that you're with, because that's how society starts to change, is when we start viewing these things differently. Parents also can make a big difference in their child's substance use trajectory if they engage in best practices. So whether or not you're a parent or you interact with parents, really trying to leverage that relationship and strengthen it pays huge dividends. So together, I guess as a final statement, together we can move the field forward and better serve those who depend on us for help and guidance. So let's do this together. So that said, thank you guys for your time today. If you have any questions, please reach out to me. My website's weinerphd.com. There's my email. I'm also constantly pushing out news and research about drugs and alcohol and public policy and all these sorts of things on LinkedIn, Facebook, Twitter. So wherever if you're on social media, please follow me, connect to me on there. I also do a video blog on YouTube where I break down concepts in addiction and psychology into little 3 or 4 minute chunks. So feel free to look me up and subscribe to me on there as well. So with that, I am done. So thank you again, and I'll take as many questions as I am allowed.
Thank you, Aaron. Appreciate it. We're waiting on the chat room right now to see if there's any questions. I don't see any hands raised at this point, but if anybody has questions, please feel free to either raise your hand or just drop it here in the chat box.
I do actually see one question that was sent in privately asking about tramadol. So tramadol is actually it's kind of an in-betweener opioid where technically speaking it is, but its addictive potential is a lot lower. So although it is possible to get addicted to tramadol, it is much more rare, and overdose is extremely rare, which is part of why it's a go-to for physicians if they're looking to bring someone up a notch, but they don't want to put both feet in the opioid camp.
Good to know. Thank you.
Well, that's the only one.
Any questions? Anybody else get any direct messages with questions possibly?
There were a couple questions about sharing the slides. So are you okay with if we send them out afterwards?
Oh gosh, yeah, and what I'll do, I know Jessica, I sent you a really big PDF. I'll shrink it down and send you one that's small.
Okay.
Doesn't bomb people's inboxes. So yes, we'll send those out for sure. All right, so one just came in. Do you worry that cocktails could go as a threat for underage drinking as well as public health? So I am not familiar with cocktails to go. To me, that sounds like an open container, which would be illegal. But you know, truly anything that makes my general thought, because I'm also very outspoken about marijuana policy, is that any sorts of policies that either glamorize or increase the amount that people are both intoxicated and addicted are not, generally speaking, good things for our society, either directly with youth or with adults trickling down to youth because of, again, modeling accessibility through liquor and drug cat, you know, just all of that, or even just pure normalization. I've got a slide and another deck, maybe this actually made national news, that how I think it was 2018 on CNN, they had one of their correspondents on a marijuana bus where she was wearing a gas mask bomb and was taking hits because it was legal to do there. As if, like, here's a way now that we party on New Year's Eve. Google it if you want to see it. But like that's the sort of thing that ideally we really want to move away from, because the more we normalize that sort of behavior, I think the worse it is for everybody, youth included.
All right, there's another question. Hi, thank you guys for the detailed, informative presentations. I do have a question. What do you think we can, as a society, to support adults who struggle with the social gap that is left when they choose to seek sobriety? It's in the chat if you want to read over it again.
Yeah. Oh, I see it now. Do you think we can do as a study? Yeah. So that's a really good question. So there are, I guess, the quick answer, kind of like there are like sober events for kids that we've heard about today. There are similar things for adults. I also know that so I have a private practice, now telehealth because of COVID, but I have a private practice that I work with people who have problems with addictive disorders. And one of the go-tos there for this are things like meetup.com, looking for groups around shared interests. That's really the core, is how can you find a shared interest with other people and then bond with them around that. COVID obviously makes that even more difficult right now because we can't gather, but I think long term, as we look into 2021 and beyond, when we have a vaccine and we're not distancing like we are right now, I think that helping people figure out what are some interests that I have that I could use to connect to others, and then helping them find those like-minded people are the best way to go about it. I think a lot of times people feel like everyone, because in their previous life, they drank all the time and everyone they were around, for example, drank all the time or used opioids or marijuana or whatever it is. They feel like that's just what everybody does. And in fact, there's a lot of contextual norming there, where you feel like this is just what everyone does, even though there's a lot of people who drink very, very rarely and who still socialize and have a good time. So just trying to help bridge people into that different group. And I do have one more private question here that went straight to me. It seems like money is often a barrier to Vivitrol or similar medications. Any tips on increasing access? So that is another really good question. My understanding is that there are a lot of medications that are generic, and even I think some Vivitrol in particular. I think in the state of Illinois, there's been some work done that even on Medicaid, it's pretty well covered to get people access to these substances. Because of the opioid epidemic in particular, I'm fairly confident that buprenorphine, for example, Suboxone, is another one. It should be reasonably affordable if you have particularly commercial insurance, and if you don't, if you have Medicaid of some sort, you can go the methadone route, which I know kind of like is like an extra like stigmatizing level, but methadone honestly is just fine. It's just as effective in keeping people sober as Vivitrol and naltrexone and as Suboxone buprenorphine. It's just something where you got to go into a clinic every day, but as long as you're working with a good ethical office, there's no problem there. So if people are struggling because of money issues, but always recommend reaching out to the county health center. They usually have great, like I've done a lot of work with the DuPage County Health Department, some with Lake, some with Will County, and I can just speak from my experience with them that they are ready and willing to help just about anyone they can in every way they can. They can probably find a solution for you.
Awesome.
All right, well, that's all the questions that I have on mine.
Well, if any more come in, if we have time at the end, we can always come back to that and circle back.
Sounds good. I do actually, speaking of my private practice, I do have a 2 o'clock. So if we run a little bit over, I won't be able to stay past then, but please, anyone interested, reach out to me via email or otherwise, and I'll get back to you.
And we can always shoot them over to you too afterwards.
Perfect. Thank you.
Yep.
All right, I'm going to mute myself. Thanks, everybody.
Thank you, Aaron. I appreciate that. Thank you, everyone, for your thoughtful questions. I appreciate it. And also, thank you, Jessica, for your presentation as well. Next, I'd like to introduce Ms. Jennifer Wagner, who will be presenting on current trends of marijuana. Now, Jenny's a clinical supervisor at Northern Illinois Recovery Center. She's a licensed clinical professional counselor and a certified alcohol and drug counselor. She's got 22 years of experience in treating patients with dual diagnosis or substance use disorder. She's worked in many different levels of care: residential, partial hospitalization programs, intensive outpatient programs, and aftercare programs. She's also worked in various positions, from providing individual family and couples therapy in a private practice setting to managing all levels of care at the clinical director of an addiction treatment center. Jenny prefers direct patient care and being primarily a therapist to continue to be on the front lines to help patients transition through treatment with the skills they need for recovery. Her areas of expertise include substance use disorder, sensory regulation, strategies to manage anxiety and depression, self-esteem issues, and codependency. Jenny holds a Master of Arts degree in counseling psychology from the Illinois School of Professional Psychology. Jenny?
Wow, you had to read it all, huh? That's okay.
Well written.
Good afternoon. Thank you for having me. Just to give you guys a little bit of other background, I've been a part of the coalition for about 2 years now. I was really looking for something in my community to do more to help at a volunteer level. And what I've seen over my career is that social piece that we were just talking about, and how that's not, either people don't know you can do things, or they're not aware, they don't have access to some of those activities or knowledge about them. So really trying to educate and do that work with either youth or adults, and sober networking, sober outings. With COVID, like everyone has said, that's shifted things, which has become problematic, because that social component of, you know, having that support with everybody and having everybody understand what you're going through is a huge part of successful recovery. So looking for other ways to be creative and do that. We've been here at the treatment center I work at currently looking at a lot of different creative techniques on how to do that with social distancing. So I will prepare you right now. I am diagnosed ADD, and I tend to kind of jump around. So I self-identify as that, and just warn people that if I'm going too fast or jumping around, just let me know and I'll slow down. I also am very willing to stop and answer questions as well, if there's something in the moment or even at the end. So I'll give you guys my slides as well, and my information too. But some of the things that I've seen over the last 25 years working in this field is some of the same teenagers I saw 10, 15 years ago smoking marijuana. Their parents had sent them to a residential treatment center. They were, not really wanting to be motivated for recovery, but those are the same clients I'm seeing now as adults with long-term addiction issues, 10, 15 years, and they've progressed. So I know there's a lot of statistics. I have some in here. I tend to not like statistics often, although those last ones were really interesting. But I just feel like sometimes having that experience as well as the statistics is really helpful, because those same kids that I've seen, 15 years ago are now, as adults, doing the system of treatment, whether it's jumping from one place to the other, different levels of care, max out their insurance, and there's just not enough resources. So is an issue that I continue to see. So I just think that's kind of helpful too, to see that that really does seem to be the trend. So going along with some of those statistics, marijuana is the most commonly used psychotropic drug in the US after alcohol. This is from the DEA website and some of their more recent paperwork. So one of the things that they are seeing is the THC levels increased in a lot of the different types of marijuana available out there. So that's some of the stuff I do want to go over with you guys, is just all of the different types, especially if it's been a while that you haven't been educated on some of these things. It's no longer just joints and blunts. Now we've got all sorts of different technology and rigs and all different kinds of concentrations and chemical processes. And I'll go through that minimally, but just so people have an understanding of why some of this stuff is becoming so addictive, so dangerous, and why people are ending up in ERs more often. and having more long-term issues because of the higher potency. I'm just going to minimize this. I apologize. Technology is not my friend usually. Okay. So obviously the ingredient is, THC that goes into the bloodstream. So those concentrated different products have, again, I have worked in the field a long time where I know a lot of people in the community, different hospitals in the area, and I've worked in ERs as well. And that's something that I see a lot more of is hospital occurrences for people using marijuana. So before, you might see like a couple of cases, and that just continues to increase while people are, taking edibles and not expecting to have those same outcomes or having psychotic reactions when before that wasn't an issue, or maybe not as often an issue. So we've seen a lot more of the medical emergencies related to marijuana increase, whether it's people having panic attacks, trouble breathing, heart racing, tachycardia, things like that. Some of the statistics on the Drug Abuse Warning Network, DAWN system, that's really interesting. I look at that every year just to see some of the differences over the years in which things end up in the ER. It's one of the things I talk to other professionals about is what are you guys seeing right now, what's common? And a lot of people right now are seeing this increase in addiction and treatment. The recidivism rate of people coming into treatment, even for marijuana use, it's increasing steadily. There might be other substances that they use, but a lot of times people primarily go back to marijuana, and that can be something that then sparks those other drugs to come back into their system by use. So this was interesting to me, just the impact of that, how many were related to marijuana, which has increased. Again, some of the stuff is outdated. It's hard sometimes to find credible research that's up to date because they have to compile the data from different areas and also weed out, what things were actually just written in the chart as marijuana in their system versus was this due to the marijuana? Was this due to increased potency? So all of that's not always clear. Could be other factors too, but they are seeing an increase. And also, like I said before, the psychosis, panic attacks, increased referrals from hospitals to treatment centers, to detox facilities, and to outpatient programs. Seeing a steady increase throughout the year. Historically, the treatment centers that I've worked in have kind of had peak seasons, and we're seeing that every month has been a peak season, much more than ever before. And again, some of that, again, the opiate epidemic, like Dr. Weiner talked about, we're seeing, of course, an increased overdose rate, especially with COVID, but especially with medical marijuana and people with co-occurring issues, and seeing that become something that's leading them back into treatment as well. There's also not a lot of resources for patients. If you have commercial insurance, we have a lot of patients who have been through the systems multiple times, and they will start to cut you off. They'll start to say, like, what's going to be different this time? Why should they be in treatment? Which then is blocking them from getting that support they need. And the insurance starts to dictate the treatment, which some clients, of course, can manipulate that. But typically, patients are, where I work currently, they're willing to come in, they're adults. It's a 90-day program. It's got supportive housing. It's very structured. And we have patients that are wanting to walk through the doors, and sometimes the insurance companies will still say it's not appropriate, even though they meet the criteria that's described in the ASAM. So that's another thing that we're seeing is insurance companies becoming more resistant, especially with marijuana use. If that's their primary diagnosis, that's been a concern for treatment. But at the lower levels of care, it's not as serious as what we're finding, like outpatient, lower levels of care, but sometimes people tend not to do well with those lower levels of care. So a lot of people are struggling with getting treatment, and then with Medicaid, a lot of the beds are full. So that's been an ongoing issue. There's a lot of programs that pop up, 501c3s to help that, but there's only so many beds and so many treatment centers. So it is becoming an issue. Has been an issue, but continues to be. So some of this information Jessica had already presented. So again, increase in use. This is from NIDA, the National Institute of Drug Abuse. So young adults, because we typically work with adolescents. So again, increasing marijuana use, daily use at younger ages. And people are reporting use at 10 years old, 8 years old, younger and younger. And again, some of that stigma has decreased. Living in King County, seeing a lot of that with even what Jessica was saying, where the perception is really starting to shift to it's safe, it's a plant, it's okay, versus the dangers that they might have been taught in grade school. So again, vaping devices is another thing. We've seen more and more teenagers with these marijuana pens, the vaping devices with the high potency THC, bringing those to their jobs, bringing those to schools. A lot of the schools are struggling with finding them, knowing what to look for. There's been something that we've been doing to increase training in the school districts to educate them. The police department does that as well, to help show them some of those devices, what they look like, how to find them. And then some of those pods, it's almost impossible to know sometimes if it's THC, if it's other chemicals, if it's an e-cigarette. So that's something that people are just carrying with them. You're seeing more and more, especially teenagers, become the norm, which is concerning. So one of the things I wanted to talk about was just all the different methods of use. Sometimes people are not familiar with all of the different or additional ways that people are using marijuana. So from medical to recreational, we have topical, so any of those transdermal patches, bath soaks, lotions, oils. Some of that can be for chronic pain management, but again, if it's in the house, we see a lot of kids taking them, trading them, giving them to others, or using them themselves. A lot of stuff online you can order, again, like Dr. Weiner had said, on the dark web, and just even on some websites that are not as monitored, or out-of-country websites as well. Sublingual, so under the tongue, or tinctures, alcohol or oil-based extracts. So those are things that you can be taken under the tongue. They have a shorter duration than eating it or ingesting it, but it still hits you quickly. So people are having a reaction quite quick. They may not expect with those higher rates of concentrations of THC. Sprays, I know they have that with even opiates for cancer patients or chronically, terminally ill patients. That's something that, again, high potency and can hit the system pretty quickly. Suppositories. There's also been an increase in elderly use of marijuana. So that's something that I've heard more consistently from hospice workers, as they're using suppositories, other ways, because they might have other issues, other chronic health problems, but it's helping with chronic pain or other things. So that's something that was newer to me to find out. But ingestion, so your edibles, infused beverages, capsules, infused oils or butters. That list of edibles is endless. And earlier talking about glamorization, that's something that we've seen with alcohol, we've seen with cigarettes, we're seeing that with vape pens and all different devices for that, e-cigarettes, and we're seeing that with all of the edibles. Some of the stuff you look online and they have like videos that are ridiculous, like they're selling to a celebrity, or you have to have this item and you have to have it in every color and it's shiny and pretty and we're going to do this to it, and it's pretty outrageous, the amount of marketing and advertising that they do to lure people in and to get young people especially interested in it, having the next item, the newest item. And a lot of times parents don't even know what half the stuff is. So, you know, they might walk past it and think it's, you know, just a device or something versus what it could actually be. So that's a concern, as well as educating parents and families on what these things look like. Granted, there's a million different options, but as much as possible, helping educate on that as well. Inhalation, so obviously joints, blunts, devices like pipes or bongs, vaporizers, electronic cigarettes, cannabis concentrates is something that's over the last 10 years really increased, and that's that high potency again. But they have it in wax, shatter, butter, dabs. So some of those terms are probably familiar. Dabbing is something that you hear more and more young people end up going to the hospital for, not expecting that to be such a quick high and as intense. But again, it's that psychoactive component and the THC that they separate from the plant matter to increase the potency. So there's a lot of extraction methods, and it's interesting because what I've seen in the adults in treatment especially is that glamorization of crafting these things. So like microbreweries and craft beer, you're now seeing that with marijuana, where you have these dispensaries, they have your personal like butler there to like, you know, give you what you need and talk to you about all those different products and why you should use them to make a very high-end feel. They have that with cannabis as well now, just the concentrates too, where they're having the different, instead of the craft beer or the, you know, things like that, they're doing all the different extraction methods, all of the different ways that they can increase the potency and make it a cleaner high, quote unquote, because that's not actually a clean high, but that's the way they sell that. So some of those extraction methods, they utilize physical ways of doing it manually, other ways, chemical solvents, and that's where some of the main concerns are. A lot of houses you might see like on TV or in the news, not just methamphetamine explosions, but now you're seeing explosions due to trying to do some of this extraction where they found out information online on how to do it, or YouTube, tried it out themselves and have had horrible side effects. A lot of burns, burnt down the house, all sorts of stuff. So it's very dangerous, and a lot of people are trying to do it themselves. It's just for their own use or to sell. So that's a concern too. Some of those solvents though are butane, ethanol, carbon dioxide. So I wanted to break down some of the high potency concentrates for you guys, just to give you guys a little bit of information on maybe what some of the teenagers are talking about and just how that stuff is broke down, just to give you guys a better sense of that. But these ones, keef and hash, they are not created from solvents. So in theory, a little safer, which is, again, very inaccurate term in my opinion, but as far as exploding your house. But keef is that pollen-like dust that separates. So if you see a grinder in a teenager's room, or if you're familiar with that, that's what they're talking about when you're separating the buds and that dust. The potency range for that is 20 to 40%. Hash is keef that's been condensed or pressed, so that's more manual. And then they do like a flaky, sticky brick. People sometimes will cook it in the oven, make bricks out of it. It can be smoked in a joint, added to joints, and that hash THC potency range is 40 to 60%. So again, a little bit goes a long way for people, and sometimes they don't understand that. And there's a couple other different kinds, back to the ones that do use solvents, that rosin, wax, and shatter. There's a product called a dab rig that people use to smoke it out of, and that's something that looks similar to a glass bong. It sets up to bring the vapors through rather than the combusted smoke of the cannabis flower. So it doesn't require the solvents. But then again, the same thing with the potency range, 60 to 80%. It's pretty high. And then these other two, these last two, they call them BHO, so butane hash oil, because typically butane is used, but highly flammable, again, dangerous, but people are soaking cannabis in that to separate the plant and the cannabinoids. And then the difference between the two are just the cooling process. So the consistency, one will be waxy, has a lower melting point, and one is more of like brittle, shattery. That's why they call it shatter, because it looks kind of like peanut brittle. But it's removing those excess lipids, waxes, terpenes that they find. So they're trying to take everything out of it that could be dangerous, which again is not a foolproof process. So you see the potency range on those. So the wax 70 to 90% THC, the shatter 75 to 90%. So that's really high potency. I did put a couple of pictures of the dab rigs, just because something that you might not be familiar with. There's a million variations, but there's a couple different options. So these are things that you see around the house. You would be concerned most likely, and things that people are finding at schools. People are being bringing some of these into treatment, and of course having them confiscated. But so the wax is also smoked using a dab or oil rig. Same thing, it's got the dabbing on the nail. So the problem with this again is it's instantaneous high. So if you take a puff or two to a joint, if you compare that to drinking a beer, then a dab is like the cannabis equivalent to taking a shot. So it's intense. So you have the greater likelihood of people having addiction, anxiety, paranoia, increased heart rate, ER visits. And all of this has become worse during COVID. I'll talk more about that in a little bit, but definitely a lot of kids are even just like experimenting with a lot of this stuff and trying that stuff on their own. Boredom is a huge trigger for people, unfortunately, and COVID has increased that significantly. So again, that high is instantaneous. So these are just some pictures to see the different consistencies of that. People keep them in sealed containers, tins. Edibles, again, whether they're getting them from friends, online, or if it's an adult buying them at the dispensaries or medical use. You can see a million different variations. Just like the pharmaceutical companies, you're seeing a lot of like that, how do we make this in every form and make the most money off of that, which has been an interesting process to see expand, even now into different kinds of infused drinks where people can drink it, down into sodas, kombucha, all of the different energy drinks, and adding THC into it. So a lot of different variations of that. But people typically, when you eat it and ingest it, you're feeling the effects after 30 minutes to potentially to 1 to 3 hours. Everybody is different in that manner. It takes longer to digest, but a lot of times people think it's not working. They want it to work immediately or faster. So you see people that are eating more and either going into like an overdose from that or having increased symptoms of anxiety, paranoia, going to the emergency room thinking they're going to die or have a heart attack. So that's a concern as well. So again, from smoking where it might only take a couple of minutes, edibles have to be absorbed into the bloodstream through the liver, so it takes longer. So there is a higher potential for an overdose. These are pictures of just all the different types of edibles, all the different types of sodas. I mean, that list again is endless. So, but again, with some of these products, it's hard to see how much THC is actually in them. Again, if you're ordering online or from a different country, none of that stuff is regulated the way even here with some of the regulations. there's been issues. So everybody has different metabolisms, so that can affect it. Some of the side effects, again, psychotic episodes, hallucinations, paranoia, panic attacks, impaired motor ability. I've also seen several clients come through treatment that have had aggressive episodes under the high potency THC. So whether they're attacking somebody that's just not typically how they respond or react, by getting physically aggressive, or not knowing where they are, having that psychotic episode. They've never had mental health issues before. So a lot of changes in that. I did want to include some of the information on the endocannabinoid system, because there's more and more research on this now, and how it affects the brain. So the chemicals, the cannabinoids, along with the receptors, make up this system. I'm going to shorten it to ES because it's long. But long-term use of marijuana has been linked to mental health issues in some users, sometimes temporary, sometimes long-standing. There's research that suggests as well increases potential for schizophrenia to have, and if you already have that, to have worsening symptoms or earlier symptoms. But again, the research is kind of back and forth on some of these things, where depending on where you're going through. I really like this chart, and this is from the Scholastic. So it is interesting that they have all of the brain structure, what it regulates, and also how the THC affects it. So different parts of the brain, because again, when you look at all the different things it affects, this makes a lot of sense on why does it affect all those different things. So they have all the different reaction time issues, the panic and paranoia, impaired coordination, impaired memory, increased appetite, altered thinking, judgment and sensation, euphoria, and altered pain sensitivity. And just showing all the different areas of what that hits and where those receptors are. So how it can affect the body in a lot of ways, where some people get that relaxation, increased appetite, sedation, or more social and calmer. Other people have the opposite effect, so it depends, but definitely consistent on affects memory and learning, especially with youth. Difficulty in thinking and problem solving, impaired judgment, reduced coordination, distorted perception, decreased blood pressure, increased heart rate, tachycardia, confusion. So again, similar to as above, but perceived risk is one of those things that has changed over time, especially now with legalization. Jessica talked a lot about that earlier, so I'm not gonna go into all that with you guys again, but that's been consistent here as well in my experience at the treatment center. A lot of people are, saying, I'm not gonna use all these other substances, but I will go back to marijuana. It's legal now. I'm gonna use it for my anxiety. I'm gonna use it for this. But then they're not able to stay sober. Keeps those channels open in the brain. So it's difficult for them to have consistent sobriety. So some of the issues with teenagers using, like we talked about a little bit before, is that they're still developing, they're vulnerable. Again, there's some of those misperceptions of it's harmless because it's legal. We do use the example a lot about alcohol and even medications. You have to look at those pros and cons, cost, risk, benefit of side effects. So that's something that sometimes teenagers don't quite grasp or make excuses for, depending. So legalization, that's something that's affected as well. The federal legalization, it's not. So there's federal law still says that it's not legal for medical or recreational use. The DEA has a lot of information on their webpage about the scheduled drug scheduling system. So Schedule 1 drug breakdown is it's not currently accepted as medical use in the US. That one they are using for some medical use, but There's a lack of accepted safety for use under medical supervision and a high potential for abuse. So it's still listed under that federally. However, state by state, things have changed where obviously in Illinois now in January 2020, things have been legal for consumers over 21. They can buy from specific places without a medical card. There was just an article this morning that Gil sent us about Elgin potentially having a dispensary put in. So they're expanding now. But it's still a possession of 30 grams, which is a lot, about an ounce. So you can still have that. For the concentrated stuff that we were talking about, 5 grams. So the cannabis infused products like edibles, all of those, 500 milligrams of THC. So again, there's limits, but the limits are quite significant. But again, they can't be used in public places, on school grounds. So there's some rules around that, or driving. Gil, did you just send a time thing? Am I running out?
Yeah, I just want to let you know.
Okay. Sorry, I'm trying to go fast.
No problem.
But the other thing is driving and marijuana use. There's information out of Colorado now. There's information out of the transportation department that is giving statistics on what they're seeing. I know police officers are a good source of information just to see what's actually happening versus what we were expecting to happen, and how those people are responding with the legalization and driving and tickets and arrests, things like that. So there is an increase already. And I would continue to expect that to increase and be consistent with Colorado's data. So in the nature of time, I'm going to just skip this. But with COVID-19, I guess I just want to say that there is a lot of biased information out there. There's not a lot of quality research yet on just how is it going to be affecting them. It's similar to cigarettes though, where if you're already having irritation in your lining of your lungs, you could be more susceptible to COVID-19. So that's a concern. Also the hand to mouth touching, the CDC is reported being a concern, especially if you're a smoker of an e-cigarette. So the biggest concern that we have is we're seeing so many people come back through the doors of treatment. We're seeing so many relapses, so many deaths, like the doctor was talking about, not just opiates, many different substances, alcohol as well. But right now with COVID, it's just affecting mental health. It's affecting boredom, that isolation, being home with family that could be unsafe or also using drugs. So it's just very difficult for them to stay sober potentially or have good discharge plans right now with the lack of resources or the lack of physical contact with people. So it's a really hard time in treatment, and continuing to find creative ways to help people is going to be crucial. And that's all I've got. So if anybody has any questions, I'll do my best to answer them.
Thank you, Jenny. I appreciate it. I'm looking at the chat. There's no questions, and as of right now, it doesn't look like there's any hands raised either. So if anybody has questions, now's the time to ask. In the meantime, I just wanted to thank Jenny for your information. Definitely not any easy answers to some of this stuff, especially as it's unrolling and progressing, and just seems like sometimes the forces are against us and in other ways maybe they're in our favor. So no easy answers, but I think that's the beauty of a coalition, right? We all get together, put our heads together, grab the data, and really try to make sense of it to protect our youth and our community. So let me just look one more time in case there might be any last minute questions. Rhea, thank you, you're welcome. She's thanking everybody for sharing the knowledge. I see no hand raised yet. And
There's one that just came in, Gil.
okay, here's a question, Jenny. How powerful do you think marketing and social circles are in enforcing these unhealthy habits?
Huge. It's interesting, even among coworkers and people in the recovery community that I'm part of, with the e-cigarettes, and when things went over to vaping, it's like people are comparing and looking at the hot new item, and I got to get this hot new vape juice, and now it's like adding the THC into that. Just even doing some research for this, because I do work more with opiates than marijuana, but I do see like these just crazy videos geared towards, this is sexy, this is a big deal, like you got to have the next hottest thing, like technology. It was mind blowing to me that that kind of money is going into the marketing. Also with the infused beverages, it was interesting how many billions of dollars all the beer companies, Coors, a couple other ones, were dumping like billions into THC infused, the new product, to make them money, which again, knowing who's going to be looking at those things, obviously it's concerning.
Jared, can you mute Gil? I'm pretty sure.
Wow,
There we go.
okay, thank you so much. I appreciate that. All right, great. Somebody did ask about Jenny's slides as well, and we'll definitely get all the slides out to you guys from all the presenters. Thank you again, Jenny, for everything, for sharing your expertise with us. Aaron, Jessica as well, we want to thank you. But I especially want to thank all of you who took your precious and I know irreplaceable time to join us today. It's truly appreciated. Please don't forget to fill out the evaluation, which you'll be getting in a follow-up email. And if you have any questions regarding at all your CEUs just being offered, please email us at cshelgin@gmail.com. That's cshelgin@gmail.com. I'd like to leave you with a parting thought. It was a Facebook post that we got from a mom and a volunteer recently. And this is what she says. I recently volunteered with CSHE, who are creating a safe place for kids in Elgin to learn how to do life, and helped chaperone a dance for 220 plus middle school kids. Loud music, pizza, areas for them to fellowship. I watched as these at-risk kids were given a chance to be like everyone else. The event was free, so no one was left out. The playing field was level. They all knew how to jump and built out the words to the hip-hop songs. My role, pull up your pants. Don't stand so close, but you can hold hands. Please remove your hat. My pay, seeing the joy on faces of young kids growing up in adverse conditions, feeling alive, feeling hope, having fun, and knowing at least for one evening that some people care. And for some, this may be their turning point. So that note really moved me when I first read it, and it moved me because I like to think that what we do, this is why we do what we do. And I like to think that it's why you do what you do. So I want to thank everyone for joining us today. I hope you have a safe and healthy rest of your week. Thank you for joining us.